Chapter 5 Hemodynamic disorders, thromboembolism and shock. So basically, first we have disorders of perfusion such as hyperemia and congestion. Hyperemia, definition, it is an active process because of arterial dilation which leads to increased blood flow to a tissue or organ. So physiological causes are exercise such as increased functional demand, and then the pathological causes are seen in inflammation. So it is responsible for two causes, that is rubor and color, redness and heat. And again, now moving on to congestion. Congestion is a passive process resulting from reduced venous outflow of blood from tissue or organ. So again, we have different types based on systemic and local, and again acute or chronic. So systemic, we can see it in congestive heart failure. It involves the spleen, liver and kidneys. And local examples, we have deep vein thrombosis, which congests the leg veins leading to edema of the lower extremity, and also local congestion at various sites because of bandage, plasters, etc. Next, we have acute congestion, which develops during shock or sudden right-sided heart failure. Chronic congestion, it usually produces edema in which the venous outflow is reduced. So appearance, the congested tissues have a dusky reddish blue color or cyanosis due to the stasis of RBCs. Moving on to CVC lung. CVC lung, it is caused by left heart failure or left-sided valve failure, such as mitral stenosis. So what happens is, because of left heart failure, what happens is there is a backflow of pressure onto the lungs, which reduces the flow of blood out of the lungs. This leads to chronic passive pulmonary congestion, and it increases the pressure in the alveolar capillaries, in which the alveolar capillaries become extensively filled with blood. This causes microhemorrhages. The walls of the alveolar capillaries may rupture, leading to microhemorrhages into the alveolar space. This results in release of RBCs into the alveoli, and again hemosiderin pigment accumulation, and again hemosiderin macrophages, which are also known as heart failure cells, are seen in CVC lung. Heart failure cells are seen in CVC lung. Next, it again leads to pulmonary edema, left heart failure, pulmonary hypertension, and also fibrosis. Interstitial fibrosis is seen. So that is why in the gross you can see that the lung is heavy because of venous congestion, and also it becomes rusty brown color. So it is also called brown induration of the lung, and the lung becomes firm in consistency because of interstitial fibrosis. So again, microscopically, because of interstitial fibrosis, we can see thickened alveolar septa. Because of congestion, we can see congested capillaries in the alveolar septa, and also we can see heart failure cells in the alveoli. Now moving on to CVC liver. Lung, everything was left-sided failure. Here everything is right-sided failure. So causes are right heart failure and also tricuspid stenosis and obstruction of inferior vena cava. So what happens is, morphologically, the liver increases in size and the capsule appears tense. Again, spleen also, the capsule appears tense and the liver spleen also increases in size. In CVC liver, there is nutmeg liver appearance because of alternate dark and light areas. So why is there darkness? Because congested centrilobular regions, they appear dark brown. So congestion is more prominent around the terminal hepatic venule. This is because inferior vena cava directly from the right heart, it is formed by the joining of all the central veins of the liver. So if the pressure is flowing back, it leads to centrilobular congestion, centrilobular hypoxia, and centrilobular necrosis, and that leads to darkness, okay, because of congestion. And periportal regions appear pale, so that is a dark and pale, you have nutmeg appearance. Microscopically, centrilobular region, you can see congestion and hemorrhage in the central veins and adjacent sinusoids, and the severe central hypoxia may produce centrilobular necrosis. There is thickening of central veins and fibrosis also in prolonged congestion, and there is cardiac cirrhosis, which means chronic CVC chronic condition. It can because of heart, it is called cardiac cirrhosis. It leads to cirrhosis. And periportal region shows fatty change in the hepatocytes and appears pale periportal region because of fatty change in hepatocytes. So here you can see the central vein. The central vein is fibrosed, the wall. You can see congestion of the central vein, centrilobular necrosis, but the peripheral hepatocytes are normal. Okay. Now moving on to congestive splenomegaly or CVC spleen. So there is congestion and enlargement of spleen. It is because, see, if you take the portal vein, it is formed by the splenic vein on one side. So intrahepatic obstruction or cirrhosis of the liver is the main cause of CVC spleen. Extrahepatically, there could be obstruction of the extrahepatic portal vein or splenic vein by any inflammatory condition of the portal vein, which is called pili phlebitis, or it could be spontaneous portal vein thrombosis, or systemic congestion such as chronic pulmonary right heart failure, etc., just like liver. Now, moving on to the morphology. So the spleen is enlarged, it is firm and it is tense, the capsule is thickened. And again, enlarged CVC spleen shows hypersplenism. That is why there is pancytopenia. It leads to hemorrhagic abnormalities, thrombocytopenia, pancytopenia, takes off the cells. So hypersplenism. So microscopically, you can see dilation and congestion of the red pulp and capillarization of the sinusoids, which may occur, in which the sinusoids, they are normally open, but because of fibrosis they become closed. So capillarization of the open sinusoids may occur. The fibrous capsule is thickened. And again, they may show Gamma-Gandhi bodies, which are iron or iron containing, so hemosiderin is present, iron plus calcified foci and fibrotic foci of old hemorrhages. So there is a slowing down of blood flow from the cords to the sinuses, hepatic cords of Wilrod to the sinusoids, which prolongs the exposure of blood cells to macrophages in the spleen, leading to excessive destruction or hypersplenism. So heart failure cells, they can be stained by Prussian blue stain because they contain hemosiderin, which is stained by pearl stain or Prussian blue stain. They are found in CVC lung. Heart failure cells are not found in the heart. And again, Gamma-Gandhi bodies, you can stain it with pearl stain for hemosiderin, and calcium you can stain it with von Cosa stain. Next, hemorrhage. Various etiologies are trauma to the vessel wall, which damages the blood vessels. There could be any rupture of an aneurysm. Congenitally, you can have rupture of berry aneurysm because of weakness of the cerebral artery walls, or you can have atherosclerosis, which weakens the wall and produces an aneurysm. You can have inflammation of the vessel wall, such as in polyarteritis nodosa, typhoid ulcers, or peptic ulcers. You can have cancerous invasion, so inflammation and cancerous invasion of vessel wall, and such as in carcinoma tongue. And again, bleeding diathesis, so there is defective clot formation. Examples are purpura, scurvy, leukemias, etc. There could be systemic hypertension, which raises the pressure and causes hemorrhage. So manifestations, bleeding may occur internally or externally. Internally, blood may accumulate within a tissue such as a hematoma, or it may flow into the serous cavities. So what is the clinical significance? Blood loss may be acute or chronic. So based on that, the effects range. So in acute hemorrhage, a sudden loss of 20% of blood or slow loss of larger amounts has little clinical effects, but sudden loss of 33% blood is fatal. It results in hypovolemic shock. Loss of 50% of blood volume slowly over a period of 24 hours may not be fatal. So 20, 33 and 50. And again, chronic loss of blood. So if it bleeds into the GI tract, there is external bleeding into the cavity that results in loss of iron. So there is iron deficiency anemia due to loss of iron and hemoglobin. Internal bleeding, if it goes into a hematoma and again comes back into the vessel, so it is recycled, so there is no iron loss. Edema is defined as an abnormal accumulation of fluid in the interstitial space within the tissues. So types of edema fluid, we have transidate and we have exudate. So transidate, remember the mnemonic PI. So protein rich, inflammation associated process is exudate. So it is inflammation associated, so there are inflammatory cells seen in transidates, not many cells. Again, you see LDH, you see bacterial cells which are more in exudates. And again, the color also you can differentiate. Specific gravity of exudate is more because of proteins. All these factors you can use to differentiate. And the basic mechanism is inflammation in exudate and increased hydrostatic pressure in transidates. So pathophysiological categories of edema, you have edema that is formed because of increased hydrostatic pressure, such as in congestive heart failure, and regionally you have ascites, obstruction, compression of veins, etc. Hypoproteinemia causes decreased plasma oncotic pressure that is caused by nephrotic syndrome, loss of albumin, and also protein losing, gastroenteropathy, malnutrition, etc. Lymphatic obstruction by any tumors or any inflammation or post-surgical post-irradiation causes lymphedema. And inflammation also causes edema because it leads to leakage of vessels, and also sodium retention also causes edema. So local and edema, we have it is limited to an organ or a part, so there is obstruction of a vein or lymphatic because of any thrombophlebitis, chronic lymphangitis, etc., or inflammation or immune reaction. So impedance, immune reaction, inflammation. Next, generalized edema, we have disorders of fluid and electrolyte mechanisms. So heart failure could be there, kidney failure or nephrotic syndrome could be there, and cirrhosis of the liver. So basically, from the arterial end, there is release of fluid into the interstitium, and into the venous end there is absorption of the fluid back, but small amount of fluid, approximately 10%, is left in the interstitium. This is taken out by the lymphatic vessels. Okay, it enters the lymphatic microcirculation and then it goes into the thoracic duct, left subclavian vein, and enters the bloodstream again. So this movement of water and salts between the intravascular and interstitial spaces can be explained by Starling's forces. So basically, hydrostatic pressure is a pushing force. So it causes blood to move. Capillary hydrostatic pressure causes fluid to move from the vessel to the interstitium, whereas oncotic pressure, it is caused by proteins, and it is a pulling force. Wherever it is there, it pulls the fluid back. So increased hydrostatic pressure, it causes edema, as in the case of local increase in hydrostatic pressure. So there could be deep vein thrombosis, which causes the bloodstream behind it to just become static. So static pressure increases. It causes edema. There could be postural edema. If you stand for a long time, there is postural edema in the feet. And there could be generalized increase in hydrostatic pressure, generalized increase in case of chronic heart failure. So there is congestion. And right-sided heart failure, it causes pooling of blood on the venous side of the circulation. It increases the hydrostatic pressure in the venous circulation. Left heart failure causes pulmonary edema. Next, there could be decrease in the plasma osmotic pressure, which is dependent on albumin. So there is reduced albumin synthesis in case of liver disease, or such as cirrhosis or protein malnutrition, and protein losing gastroenteropathy, and loss of albumin, again in case of nephrotic syndrome. Next, sodium and water retention. There could be excessive RAS activation, due to which there is increased hydrostatic pressure because of increased plasma volume. So again, mechanism of generalized edema, we have all this. So decreased plasma osmotic pressure, it causes increased movement of fluid from the circulation to the interstitium, reduced intravascular volume, there is decreased renal perfusion, renin-angiotensin system, and there is edema. The mechanism of cardiac edema is that in congestive heart failure, there is decreased cardiac output. So the heart cannot pump enough blood to the kidneys, and the kidneys think that they're not receiving enough blood. They try to conserve fluid by activation of renin-angiotensin system. And then again, ADH also, it retains water, and excess water plasma volume increases the hydrostatic pressure and further causes cerebral edema. And again, we have all these other causes. So again, congestive heart failure also increases congestion and capillary hydrostatic pressure and leads to edema, and all these other cases. Lymphatic obstruction, it can be there in lymphogranuloma venereum. It can be there in cancers which infiltrate the lymphatics, such as pudendal appearance of the breast in breast cancer. There could be outside cancer compressing the lymphatics, such as tumors obstructing the thoracic duct. There could be surgical damage or radiation damage of the lymphatics, and also parasitic infestations which block the lymphatics, such as in filariasis. They also cause lymph node fibrosis. And elephantiasis is seen because of swelling of the external genitalia in the leg. And again, hereditary disorder, there is Milroy's disease. There is abnormal development of the lymphatics. Edema may be seen in both limbs, both lower limbs, one or both lower limbs. So morphology, it can be easily detected on cross-examination edema. So it is common in the subcutaneous tissue. Subcutaneous edema, it is dependent on gravity. It is termed dependent edema. So when pressure is applied, especially on the lower extremities because of gravity, there is pitting because of displacement of the interstitial fluid. Edema of renal origin affects all parts of the body, especially it is initially observed in tissues with loose connective tissue, such as the eyelids, periorbital edema, especially in scrotal region. Pulmonary edema, it is seen in left heart failure, and again there is frothy blood tinged fluid because of mixture of air edema and extravasated RBCs in the lung. And edema fluid is seen in the alveolar septa, and it reduces the diffusion of oxygen, and the edematous fluid also favors bacterial infection. So what are the clinical consequences? There is subcutaneous cardiac tissue edema. It represents an underlying cardiac or renal disease. Pulmonary edema because of left heart failure. Brain parenchymal edema because of ADH or whatever. Mixed edema in case of hypothyroidism. It is pitting because of glycosaminoglycan deposition in the visceral organs. And papilla edema, swelling of the optic nerve head. Because there is a concentric increase in pressure encircling the optic nerve, which reduces the venous outflow from there. It causes swelling of the optic nerve head. And the causes are compression of the nerve and raised CSF. Now moving on to normal hemostasis process. So first, whenever there is injury to the endothelium, there is exposure of the highly thrombogenic subendothelial extracellular matrix, which has collagen and von Willebrand factor, which causes platelets to come to the site. So before that, first, whenever there is injury, there is immediate reflex neurogenic mediated arteriolar vasoconstriction. It is a neurogenic process, reflex, and it also causes secretion of endothelin, which causes vasoconstriction at the area. Next, there is primary hemostatic plug formation, due to which whenever there is injury, the subendothelial collagen and von Willebrand factor is exposed, and due to which platelets are attracted to that site. So damage exposes the von Willebrand factor, and that causes that causes the initiation of formation of primary platelet plug. So first there is platelet adhesion and shape change. So first initial step is adhesion of platelets to the subendothelial apertures. So what happens is platelets have glycoprotein 1b9, which binds to the subendothelial collagen via von Willebrand factor. Okay, deficiencies of von Willebrand factor cause von Willebrand disease or GP1b. There is Bernard-Soulier syndrome, which can produce bleeding disorders. Next, after attaching to the structure, platelets undergo shape change. So there is dramatic change in the shape of the platelets. They change their shape from round to spiky sea urchins. So this change in shape is accompanied by changes in the glycoprotein 2b3A receptor that is externalized, and there is increase in affinity for fibrinogen. And also along with shape change into sea urchin, there is translocation of negatively charged phospholipids to the surface of the platelets, and this again binds the calcium and serves as a formation of the coagulation factor complex. Next, after shape change, platelets release granule content which contain ADP and thrombin. So thrombin, it activates platelets by switching on the PAR receptors, protease activated receptors, and ADP also causes further platelet recruitment to the site. Next, so once further platelets are recruited to the site, they aggregate. So this is done via GP2B3A receptor site, and there is fibrinogen bridging from platelet to platelet. So inherited deficiency of GP2B3A produces a bleeding disorder called Glanman's thrombasthenia. Okay, so activated platelets also produce thromboxane A2, which induces stronger aggregation of platelets. So this all results in formation of primary hemostatic plaque. So first platelets come and attach, they undergo adhesion, then there is activation, shape change, etc., and then there is aggregation. Next, secondary hemostatic plaque, there is fibrinogen deposit. So first, exposure of tissue factor or factor 3 at the site of injury activates the coagulation cascade. So 3 activates 7, which activates 9, which activates 10, which activates thrombin. Thrombin, what it does is it is an potent activator of platelets and initial platelet and it causes further platelet aggregation, which is reversible. So activation of thrombin, however, stabilizes the platelet pug by causing further activation and aggregation, which promotes irreversible contraction of platelets. Then thrombin again cleaves fibrinogen to insoluble fibrin, which forms a fibrin meshwork, which contracts the platelets, forming an irreversibly fused mass. And RBCs and leukocytes also get trapped within the fibrin meshwork, and they're found in the hemostatic plugs. This is called secondary hemostatic plug because fibrin is also formed. So the solid permanent plug so formed prevents any further hemorrhage. Finally, there is clot retraction, which is stabilization or resorption. So polymerized fibrin and platelet aggregates contract and form a solid permanent plug. This prevents further hemorrhage. So what are the functions of the normal endothelium? It has both anti and prothrombotic properties. So antiplatelet effects, what are they? Intact endothelium, it prevents adhesion of platelets by preventing exposure of subendothelial collagen or von Willebrand factor. It also produces inhibitors of platelet aggregation such as PGI2, nitric oxide, etc. and ADPase. Next, anticoagulant effects. It has antithrombin 3, which is a heparin-like molecule. It has thrombomodulin, which activates protein C and inhibits clotting. And also there is tissue factor pathway inactivator. It also has fibrinolytic effects because it synthesizes tissue plasminogen activator. Next, prothrombotic properties, what are they? Whenever there is injury to the endothelium, it exposes the von Willebrand factor and subendothelial collagen. It also produces the von Willebrand factor. Procoagulant effects, they synthesize tissue factor in response to cytokines, which causes the coagulation cascade to occur. And antifibrinolytic effects, they synthesize PIs, so plasminogen activator inhibitors. They reduce fibrinolysis and favor thrombosis. So thrombosis is defined as a process of formation of a solid mass in the circulating blood from constituents of flowing blood. Solid mass formed is called a thrombus. So etiology is by the Virchow triad. The mnemonic is CHEF, so HC for hypercoagulability, E for endothelial injury, and flow for alteration in the normal blood flow. So physical endothelial injury, it is important for the formation of thrombus in the heart or the arterial circulation. Endothelial cell injury promotes adhesion of platelets at the site of the injury by exposing subendothelial collagen or von Willebrand factor. So the causes of physical endothelial injury are MI, so direct infarction, and again any vegetation on the valves that can also produce injury. Then arteries, they can cause atherosclerosis as a form of injury, and DIC from the capillaries. So mechanism, physical loss of endothelium, it exposes thrombogenic materials and they release prothrombogenic tissue factors, and there is local depletion of antithrombogenic factors like PGI2. Next, endothelial injury culminates in endothelial dysfunction, which is defined as an altered state which induces an endothelial surface that is thrombogenic or abnormally adhesive. So what are the causes? You have hypertension, metabolic abnormalities like homocystinemia or hypercholesterolemia, and radiation injuries, bacteria, etc. So mechanism, endothelial dysfunction can disrupt the balance between prothrombotic and antithrombotic properties by producing more procoagulant factors and synthesizing less anticoagulant factors. Next, alterations in the normal blood flow. Normal blood flow is said to be laminar, so the molecules in the velocity of the fluid in the middle layer is more because the peripheral layers are in contact with the wall, which has several impeding factors like cells, etc. So any turbulence causes alterations in the normal blood flow. Turbulence is a disturbed movement of the blood. The streamlined flow may be disturbed by normal anatomy and pathological processes. So normal anatomy, any branch point can cause turbulence. And again, pathological processes such as tumors, they can also cause any turbulence. And stasis, it is a major cause for venous thrombosis. So the mechanism, it promotes endothelial injury and activation. It prevents platelets into contact with the endothelium. It prevents cleansing of activated clotting factors, and it prevents flowing in of clotting factor inhibitors. So what are the clinical disorders? Heart, acute myocardial infarction. It is related to formation of collaterals in elderly people. Because of collaterals, new branching, so there is turbulence. Next, arrhythmias and atrial fibrillation, they are associated with mitral stenosis, so that also causes turbulence. Next, dilated cardiomyopathy. Then arteries, you have ulceration of atherosclerotic plaques and aneurysms, which again cause local stasis. Other causes are hyperviscosity such as polycythemia vera and RVC disorders. Next, hypercoagulability. It is defined as a systemic disorder associated with increased tendency to develop thromboembolism. So causes, it is a frequent cause of thrombosis. Primary causes are there and secondary causes are there. So primary causes, you have protein C and S deficiency, antithrombin 3 deficiency, etc. and increased prothrombotic factors such as activated factor 5 lead-in or high coagulation cascade factors or homocystinuria. And secondary, you have other high risk factors such as prolonged bed rest, myocardial infarction, DIC, cancer, etc. Next, mural thrombi. It is attached to the wall and it projects into the lumen without completely obstructing the lumen, whereas occlusive thrombi, they occlude the lumen of the blood vessel. So vegetations, they are thrombi on heart valves. They appear as polyploid masses projecting into the lumen. So the types of thrombi, you have arterial or venous type. So moving on to the morphology, first layer of the thrombus, on the endothelium you have the platelets adhering to it. So there is a platelet layer. On top of it, fibrin is deposited to form upstanding laminae which anastomose to form an integrate structure which resembles a coral. So there is a coralline thrombus. In between the upstanding laminae and anastomosing fibrin network, the RBCs, they get trapped. So retraction of fibrin produces a ribbed appearance on the surface of the thrombus. So RBCs get trapped like this. Like this, it produces a line of stan appearance. So both gross and microscopy of thrombus show alternating dark areas of platelets held together by light areas of platelets held together by dark retracted area of fibrin with RBCs. They are called lines of Zahn. So sites and types, the thrombi, the size and shape depends on the site of origin and its cause. So cardiac thrombi, they usually develop at sites of turbulence or endocardial injury. And valves, thrombi and heart valves are called vegetations, are more common on mitral or aortic valves on the left side. So differences between arterial and venous thrombus. So basically venous thrombus is caused by stasis and arterial by injury to the endothelium. Rate of blood flow is slow in venous thrombus and it is occlusive, whereas it is mural in arterial thrombus. So color, obviously it is red blue in venous thrombus and grey white in arterial thrombus. Lines of Zahn are more prominent in arterial thrombi and more trapped RBCs are there in venous thrombi. Propagation, both of them propagate towards the heart. So you can say retrograde in case of arteries and antegrade in case of veins. And effects are ischemia in case of arterial thrombus and edema and thromboembolism in case of venous thrombus. Next, so these are the differences. And postmortem clots, basically they occur postmortem after death. So the RBCs settle down and form a basal layer which gives a gelatinous current jelly appearance. And on top, there are less cells and it is yellow white. It resembles chicken fat. Only there is coagulated plasma without RBCs. So RBCs in the bottom layer, coagulated plasma on the top layer. So fate of thrombus, again the thrombi, first it may totally disappear. Otherwise there may be propagation of the thrombi. The thrombi may grow and increase in size and they can become occlusive. Mural may become occlusive and then they can grow retrograde or antegrade. Next, they can embolize. They can detach and form emboli and the effects depend on where they dislodge. Next, organization. So if the thrombi are not dissolved, there can be fibrosis and they can get organized, and there can be canalization or recanalization, formation of new vascular channels for the blood to flow, and there could be mycotic aneurysm. And these are the differences. So antemortem venous thrombi are firmly attached to the vessel wall. Postmortem clots are not attached. They are gelatinous. There is current jelly and chicken fat appearance. They have the shape of the vessel in which it is found, and lines of Zahn are absent. Moving on to venous thrombosis, you can have superficial venous thrombi. They develop in the saphenous veins. They cause local congestion and pain, and they predispose to varicose ulcers. They develop in varicose veins. They cause varicose ulcers. Next, deep vein thrombosis. It is found in association with venous stasis and hypercoagulable states. It occurs in the deep and large veins of the knee. So effects, there is venous block. So it is prone to embolization of the lung, and is also but the venous block is balanced by the development of collateral channels. So the pathogenesis of deep vein thrombosis, first what happens is there is a formation of primary platelet thrombus. So damage to the intima of the vein causes platelets to aggregate there. There is pale platelet thrombus. Next, there is coralline thrombus formation by fibrin accumulation, and the platelets along with fibrin form upright laminae, and then there are trapped RBC layers. It produces line of Zahn appearance. Then this can occlude the thrombus. Further growth of the thrombus, it occludes the entire lumen of the vein, and then there could be consecutive clots. So the occlusive thrombus, it stops the blood flow, and the blood column beyond the occluding thrombus clots to form a consecutive clot. Then it can propagate. There are two methods. There could be thrombus formation in each tributary, like this, or otherwise it can clot en masse in beyond the clot in one long column of blood. Next, thrombophlebitis, it is itis is inflammation of the wall of the vein resulting in thrombosis, and sterile inflammation may be produced by direct trauma, but any bacterial inflammation, it could be not sterile. Next, thrombophlebitis migrans, it is also known as migratory thrombophlebitis or Trocher syndrome. It is formed in deep-seated cancers which migrate to the Virchow's node, and it is characterized by recurrent thrombotic episodes involving the superficial and deep veins, especially of the extremities. Next, consequences of thrombi. In arterial thrombi, they cause infarctions. In venous thrombi, they cause edema and congestion in the region distal to obstruction. And forced dorsiflexion in deep vein thrombosis causes tenderness in the calf. It is known as Hohmann's sign. Next, embolization. Again, the effects depend on the site of lodgement. Moving on to embolism. An embolus is a detached intravascular solid liquid or gas that is transported in the blood to a site distant from its point of origin. So the types of emboli based on solid, liquid or gas. Solid, you have erythematous, you have thromboemboli, you have tumor masses, etc. Liquid emboli, you have fat, you have amniotic fluid embolus, and next gas, you have air embolus. Next, whether it is infected or not, if there are organisms, it is septic, otherwise it is sterile. Next, again you have cardiovascular, so cardiac causes, again you have myocardial infarction, you have valve originating emboli such as arterial emboli in case of heteromas, venous emboli, deep vein thrombosis, again all that. Okay, so cardio and vascular artery, vein and lymphatics, you have tumors, and again you have paradoxical or retrograde emboli. So paradoxical emboli, they originate in the venous circulation. They go into the right heart, right ventricle. They go to they bypass the lungs, and there is a right to left shunt. Okay, they originate in the venous circulation, enter the right heart, then they enter the systemic circulation, and they block the blood flow to the arteries. Okay, so that is about paradoxical emboli. And retrograde emboli, they travel against the flow of blood. The best example is prostatic carcinoma emboli metastasizing to the spine, especially during coughing and straining. So next, pulmonary embolism. The best origin is deep vein thrombosis. It is a source in more than 95% of pulmonary emboli. Next, the risk is major risk factor is surgery. Risk increases with advancing age, obesity, post-op infection, post-op procedure, etc. Mechanism. So basically, deep vein thrombi, they undergo fragmentation. Then they are carried through the larger vascular channels into the right heart. Then right ventricle, they enter the pulmonary arterial vasculature. So the fate of the pulmonary embolism. So basically, it can either resolve the small pulmonary thrombi, they resolve pulmonary emboli, and then or they can become more obstructive. They can become massive, and they can obstruct more than 60% of the pulmonary circulation. So first, you have saddle embolism. So if the thrombus gets if the embolus lodges at the bifurcation of the main pulmonary artery, so it produces acute massive obstruction of blood flow to both the lungs, because pulmonary artery gives blood flow to both the lungs. So it obstructs the lungs. So effects, so there is right ventricular failure, there is damming in the right ventricle, so there is failure, and then shock, because from the lungs blood is not going to the left ventricle, so there is hypovolemic shock and it results in sudden death. There could be multiple recurrent pulmonary emboli, they fuse to form a single mass, or there could be a paradoxical embolism. And consequences, there is pulmonary infarction. Okay, so if it is a small embolus, if it lodges in the terminal branch, okay, what happens is there could be a wedge-shaped infarct that can be formed. There is a red or hemorrhagic infarct because dual blood supply in the lung. It is pyramidal, and granulation tissue grows from the edges of the infarct and results in organization of the infarct and forms a fibrous scar. So clinical features, there is cough, stabbing pleuritic pain, short dyspnea, and occasional hemoptysis. So there is blood hemorrhagic infarct and you need to cough it out. There is dyspnea and cough and pleuritic pain. Pleural effusion is a common complication and pleural fluid is blood stained. Next, there is pulmonary hemorrhage, there is pulmonary hypertension, and there could be minimal effects also. Next, systemic thromboembolism. Sources of systemic emboli. You have heart. So intracardiac neural thrombi, you have myocardial infarction, mitral stenosis, etc. You have paradoxical emboli, valvular sources, etc. and blood vessels. Again, you have aortic aneurysms, you have atherosclerotic plaques, etc. So consequences: the arterial emboli can travel to a wide variety of sites, and venous thrombi, they mainly lodge in the lung. Okay, the fate, see, it could either propagate more, leading to infarction of the affected tissues, or it can fragment or undergo lysis. So major sites affected: lower extremity, it produces gangrene; brain, it produces stroke; kidney, it produces infarcts; spleen also it is affected, and there could be intestine, there could be infarction of the bowel. Okay, next, infarct spleen, dry gangrene foot, infarction of the bowel, renal infarct, and cerebral infarct is stroke. Next, fat and marrow embolism. Fat embolus consists of microscopic globules of fat with or without bone marrow elements. So this is caused by trauma to the adipose tissue with the fracture. So severe trauma, particularly accompanied by fractures of bone, release fat globules or fatty marrow into the ruptured blood vessels. Or there could be soft tissue trauma and burns. So how does it manifest? In most cases, it is asymptomatic. Sometimes it manifests as potentially fatal fat embolism syndrome, and the patient develops symptoms due to severe fat embolism. So what is the pathogenesis? There is trauma to the adipose tissue associated with fracture. There is release of emboli consisting of fat globules and or fatty marrow. Entry of fat micro emboli along with red cell and platelet aggregates into the capillaries, which are ruptured at the site of the fracture. So these emboli, they travel through the circulation and can occlude the pulmonary and cerebral vasculature. Okay. Next, biochemical injury can also occur along with physical injury. So trauma causes release of these emboli. Free fatty acids are released from the fat globules. They produce local toxic injury to the endothelium, which causes platelet aggregation and granulocyte recruitment, and this causes the entire thrombus. Next, consequences of fat embolism. So what are they? If they lodge in the emboli in the venous side, they lodge in the lungs, and emboli, they can pass into the systemic circulation. They can be arrested in the brain, kidneys, and other organs. So that is why autopsy finding, you can have numerous fat globules in the microvasculature of the lungs especially, and also in other organs. So lung, you can have ARDS, acute respiratory distress syndrome. Brain, you can have cerebral edema and small hemorrhages. And also demonstration of fat embolism. Fat is usually dissolved in conventional preparations in paraffin embedding. So that is why you use frozen sections and special stains for fat such as Sudan 3,4, oil red O, and osmic acid. So clinical presentation, it develops 1 to 3 days after the traumatic injury. So there is tachypnea, dyspnea, and tachycardia, which leads to respiratory failure, ARDS. Neurological symptoms, again, irritability, restlessness, delirium, and coma. So again, hematological findings, there is thrombocytopenia. Because the fat cells, free fatty acids and all, they use the platelets for the embolism, and anemia is there due to aggregation of red cells in the thrombus. And again, you can see ARDS and opacification of the lungs and chest radiography. Air embolism, it occurs when air is introduced into the venous or arterial circulation. Again, trauma or injury is one cause. More than 100 ml of air needs to be incorporated to cause the air embolism. Again, surgery or invasive procedures or thoracocentesis or laparoscopic procedures or CABG, all criminal abortions, all these are causes. Next, mechanism. So air or gas bubbles, they coalesce to form frothy masses which physically obstruct the vascular flow in the right side of the heart. So air bubbles are seen as empty spaces in the capillaries and small vessels of the lung or the brain. Decompression sickness, it occurs when individuals are exposed to sudden decrease in atmospheric pressure. It occurs in scuba and deep sea divers and individuals in unpressurized aircraft. So what happens is air is breathed at high atmospheric pressure by deep sea divers, and large amounts of inert gases such as nitrogen are also dissolved in the blood. But as they gradually descend into a low pressure area at the ground level, so what happens is dissolved gas, it comes out from the blood and it is exhaled. It appears as a bubble. It does not produce any injury. But too rapid ascent, what happens is gas bubbles form, and if they enter the nervous system, they cause coma or death. If they enter the respiratory system, it causes respiratory distress called chokes. So there is small vessel obstruction of the lungs and it causes edema, hemorrhage, and focal atelectasis or emphysema. And again, if it enters into the joints, it reduces the blood supply to the skeletal muscles, produces muscle pain, which is called bends. Okay. So again, workers in these pressurized vessels, especially in chronic decompression sickness called Caisson's disease, they may develop both acute and chronic forms of decompression sickness. Characteristic features of chronic form is avascular necrosis of the bone. Next, amniotic fluid embolism, it develops when the amniotic fluid along with fetal cells and debris enters the maternal circulation. So this can occur through open or ruptured uterine or cervical veins. So what happens is, it is a rare maternal threatening complication, occurs at the end of labor and the immediate postpartum period. So what happens is, from the venous circulation, from the uterine cervical veins, the amniotic fluid embolus, it enters the right heart and it rests in the lungs and causes DIC. Okay, so morphology, amniotic fluid contents we can see, so such as fetal skin, lanugo hair, squamous cells, all of these squamous cells from all these things you can see in the lungs, and also you can see diffuse alveolar damage and features of DIC. So clinical features, there is abrupt onset, there is bleeding, and ARDS. Next, you can see talc emboli miscellaneously. In IV drug uses, you can see cotton emboli because of cleansing of the skin by cotton due to venipuncture. You can see schistosomiasis, which can lodge in the lungs. You can see tumor emboli, erythematous emboli, platelet emboli, and infect emboli. Again, mycotic aneurysm, it is a misnomer because the infective agent is bacterial, not fungal. An infarct is a localized area of ischemic coagulative necrosis caused by occlusion of either arterial blood supply or the venous drainage, and the process of producing it is called infarction. Mostly the infarct is of coagulative type of necrosis. So causes of infarction, again you have arterial and venous causes. So both causes occlusion of lumen are because of thromboembolism, and external compression in case of arteries is mostly because of tumors, and veins is mostly because of strangulated hernia, or tumor, or torsion of a vessel, etc. So factors that determine the outcome of an infarct are basically the nature of the vascular blood supply. Dual or parallel blood supply is there, means the organ is less likely to develop infarction such as lung, liver, etc. Next, end arterial blood supply is there, means such as kidney and spleen. There are end arteries with no collaterals or little collaterals, so they are more prone to infarction. Next, rate of occlusion. Slow occlusion is less likely to produce infarct than rapid occlusion. Vulnerability of tissue to hypoxia. Neurons are highly sensitive to hypoxia. For 3 to 4 minutes also they can undergo necrosis, but myocardial cells die after only 20 to 30 minutes of ischemia. Next, oxygen content of the blood. So even though the oxygen content is high and there is ischemia also, they may not produce any infarction till some time. So classification of infarct, you can classify it as white or red or pale or hemorrhagic. You can classify it as septic or bland or recent or old. Next, white infarcts, they occur in solid organs with end arteries and with arterial occlusions, whereas red infarcts occur with venous occlusions in loose textured tissues with dual or double blood supply. So white infarcts occur in spleen, heart, etc. Red infarcts occur in lungs, they occur in liver, etc. So organs with extensive collateral circulation also, such as brain, they undergo red infarcts only. Reperfusion is also there. So when blood flow is re-established to the site of previous occlusion, the area is reperfused. Next, morphology, white or pale infarct. So basically, gross examination, you can see wedge-shaped infarcts. The base is seen at the apex. Sorry, the occluded blood vessel is seen at the apex, and the base is seen at the organ of the covering external surface of the organ. Next, acute infarcts are poorly defined and slightly hemorrhagic, whereas after 1 to 2 days the infarct becomes soft, sharply demarcated, and light yellow in color. Next, margins of the infarct are well defined because of narrow rim of congestion caused by inflammation, and as time passes the infarcts become progressively more and more pale and sharply defined. Red infarcts, they appear as sharply circumscribed areas of necrosis, firm in consistency and dark to purple red in color. So microscopy, both infarcts characteristically show ischemic coagulative necrosis. So microscopic changes of necrosis occur after 4 to half day. So half day necrosis. Inflammation to clear out the necrosis occurs in 1 to 2 days. Okay, acute inflammatory cells. Next, it is followed by a reparative process which begins at the preserved margins. So they are phagocytosed by macrophages. Next, parenchymal regeneration occurs at the periphery where the stromal architecture is preserved, and granulation tissue may replace the infected area which matures to form a scar tissue. Then septic infection, the infarct may get infected when it is seeded by pyogenic bacteria or septic emboli. So they contain organisms and can produce septic infarcts.